For this session, we have an exceptional lineup of speakers today. They will share their valuable expert and insight on this insulin pump. Let us begin this session. I would like to invite Chairperson Dr. Alpa Panelia Madam from Surat and Dr. Priyanka Bhalonde Madam from Pune. This is an opportunity to learn from each other and expand our knowledge in the field of diabetes. Now, over to you, Chairperson. And thank you, and I hope you will find this session very informative and engaging.
So, good evening, everyone. So, finally, we are at the end of today's symposium for the D-Genius. So, again, we have the good, interesting topic for the to debate. That is the insulin pump is for everyone, yes or no. So, I just first welcome Dr. Mithun Bhartia, referee. Please come on the stage, sir. Thank you, sir. So now I am welcoming the first speaker to favor the insulin pump is for everyone, Dr. Anushree Mehta. So Dr. Anushree Mehta has done MBBS and she has completed her fellowship in diabetology and diploma diab from the UK. She is consultant diabetologist and she is the co-founder of the Beyond Injection, a complete insulin pump clinic. And she has also speakers remains the speakers. She has an attachment with the Ramakrishna Mission Hospital and Arogya Nidhi Hospital and others, etc. Please come on the stage.
Thank you. So I think this is a very important topic considering the current advancements that have happened in this field. So for type 1 diabetes, the current standard of care is multiple daily injections, anywhere between 4 to 6 times a day, monitoring multiple times a day either by a finger prick or using a CGM device. And yet, even after doing all of these things, the blood glucose control, HbA1c, time in range for most of our patients is far from optimal. And what about quality of life? Do we even talk about that? So just let me show you a few Instagram posts from so-called diabetes influencers to give you an insight as to what they think their life is like or what they think type 1 diabetes is. So it says it is a terminal disease, we work up butts off 24 hours a day, 7 days a week, no break, no vacation, or else we will die. We fight for our health every minute for every day. And there's another post which says that if it was a job advertisement, then there would be no application necessary. Once you're randomly selected, you're tied in for life, immediately starting with no notice and no training. So I think it is just an insight into what their life for them or what type 1 diabetes for them looks like. Now, theoretically, insulin pump helps with A1C. It helps to improve glycemic variability. It helps to reduce hypoglycemic episodes, reduce complication. And from patient's point of view, it helps to reduce the total insulin dose and it helps to improve quality of life. What does the data say? So here we are talking about basic pumps. So a study of 16,000 students from the SWEET registry has shown, comparing CSII with MDI, they've shown that linear regression analysis, which was adjusted for age, gender, and diabetes duration, showed that both HbA1c and insulin dose remained decreased in children treated with the pump. Another study of 345 children on pump therapy again showed that over 7 years, over 7 years of follow-up, pump therapy reduced severe hypoglycemia from 14.7 to 7.2 events per 100 patient years. Rate of hospitalization was also lower in this cohort. It was reported that pump therapy provides a sustained improvement in glycemic control, reduction of severe hypoglycemia, and hospitalization for DKA with a matched cohort using injections. This was another very, very large study where data was taken from 3 registries, and this meta-analysis reported that CSII therapy is associated with improved glycemic control compared with traditional insulin therapies. And another study of 100 patients with CSII showed that not only there was a reduction of A1C and hypo, but quality of life parameters also improved. We know that every 10% improvement in the time in range is equal to a 1% reduction in A1C, which leads to a 40% reduction in the risk of microvascular complications. So we know that insulin pumps also help to improve the time in range. It reduces glycemic variability. Now is the age of automated pumps, and all over the world, they are talking about automated pumps, and this is the data of the automated pump where you can see the time in range of, this is real world 100,000 users, and you can see that the time in range is 72%, which is amazing for type 1s. So any of y'all who are treating type 1s, you know how you break your head when they come with the CGM reports, and it's scary to look at the fluctuation. If they come with a 60% TIR, I feel that, wow, you're doing very well. So with these automated pumps, for children below 15 years, the average TIR is 69.9, and for patients above 56 years, it was 76.8. But let's look at the Indian data, okay? So this is the Indian data where 219 subjects were on the AID, and their average time in range is 75.4%. The glucose management indicator was 6.8. Again, this was another study presented at ISPAD, and it showed that in India, post AHCL, around 160 patients, the time in range was 71%. The European data shows that the time in range improved from 60 to 72% with the use of the automated insulin delivery systems. So we have a lot of real-world evidence in favor of automated insulin delivery systems, and majority of the reports show a 10% change with the automated insulin delivery systems, and it is rapidly becoming the standard of care all over the world. This is a study which was published, meta-analysis published in Lancet, and I want to highlight here that it showed a reduced diabetes distress, a reduced fear of hypoglycemia, an improvement in hypoglycemia unawareness, improved quality of life in children and adolescents living with diabetes, in addition to all the metabolic parameters that improved. Now I know that my worthy colleague is going to talk about the cost, so I'm going to clarify the point that the life expectancy and cost effectiveness of the AID systems have already been looked at, and the treatment cost partially is offset by the direct cost savings from the avoidance of diabetes-related complications and indirect cost savings from the avoidance of lost workplace productivity. Reduced complications, improved life expectancy with consistent time in range above 70%. So these are the studies, one from Sweden and one from UK, which talks about the cost effectiveness of using the hybrid closed loop system. A landmark announcement was recently done by the NICE, which talks about giving the hybrid closed loop system over the next 5 years to hundreds of thousands of people living with type 1 diabetes. And I'm not going to read the whole thing, but this is a statement given by Colette Marshall, the Chief Executive of Diabetes UK, where they're talking about how using these automated systems can improve and lead to direct cost saving and improve life expectancy in children with type 1 diabetes. So if UK can do it, can't India think about it? We match them everywhere else. Why not in healthcare? Why do we have to lag behind there? Why can we not think of appealing to the government? We are a big group of doctors here, and we should really talk about using AID more and more, especially in all of our affording patients. So at the end, insulin pump helps to improve time in range, HbA1c. For the patient, it helps to reduce the risk of severe hypoglycemia. It helps to reduce the risk of complications. It indirectly impacts longevity and reduces costs related to complications. It leads to improved quality of life and reduced diabetes distress. Thank you.
So thank you for finishing right in time. That was very good. I think we'll have our opponent coming on stage and talking against the motion.
So I welcome Dr. Pavithra Nagaraj. She is a consultant pediatrician and adolescent endocrinologist at Bangalore, and she is the Secretary Pediatric Endocrinology Association of the Karnataka. Over to you, ma'am.
Thank you so much for that introduction, ma'am. At the outset, I would thank the Genius and Diabetes India for giving me this opportunity. My friend has already spoken why we need insulin pump and what we deal with type 1 diabetes. So just not wasting much time, and I think I would finish much before the allotted time. As all of you know, the basic principle of insulin pump is to administer the insulin at the basal bolus rate. And the basal is a continuous secretion of insulin mimicking the pancreas. So who benefits? Anushree has already told us who benefits from pumps are children who have a HbA1c of more than 8.5, frequent hypoglycemias, usually the nocturnal hypoglycemia, severe dawn phenomenon which cannot be dealt with even with using pens, recurrent diabetic ketoacidosis and requiring recurrent hospitalization, severe glycemic variability even on pens, low insulin requirements, which is very difficult to titrate either with syringes or the pens, and presence of micro and macrovascular complications, which is very rare in type 1 diabetes. So who will not benefit? Yes, there are children who may not benefit with an insulin pump are children with psychosocial issues where it is very important for them to feed the carb counting to the pump, who do not monitor their glucose frequently. Of course, if you are using CGMs, that would help here. And those who are not doing the carb counting on a routine basis, and those who are not affordable, as Dr. Anushree has rightly mentioned. There are studies, but not in India, where they have done the cost effectiveness to the management of type 1 diabetes. But I would be interested to know if there are any studies done in India and the cost effectiveness. So what are the practical issues what we come across when we are using a pump is the most common is the instrument or the pump related issue. Basically the cannula which gets blocked, which gets kinked, and there can be decreased insulin to the body. Pump reservoir, leakage or any empty pump syringe. Infusion set like not priming, kinking, blood or air in the set can cause problems. Infusion site, there can be redness, lipohypertrophies, rashes because of the continuous use of additions for the pumps. And when we come to the insulin, there can be problems related to the insulin getting cloudy, exposed to extreme temperatures, either cold or hot, and of course the battery of the insulin pumps. So the most important, why am I talking against using insulin pump is the risk factors which are involved using a pump, right? So the risk of diabetic ketoacidosis is very, very common in children who are using pumps. So it can be either equipment related or it can be the insulin related. So equipment related, as I've already told you, it can be because of the malfunctioning, either by kinking or there can be some inflammation or infection at the site, erratic insulin absorption, low batteries, and insulin in the reservoir is not topped up. When we come to the insulin related, the temporarily discontinuation of insulin delivery either by the child or family during an activity or during any event can cause diabetic ketoacidosis, and illness which requires sick day management can also have diabetic ketoacidosis. The other risk factors where we see a child using a pump is infusion site reactions, which can be masked because of the adhesives. Like we can have local skin reactions, we can have lipohypertrophies, atrophies, which can cause again erratic blood glucose values. The other is risk of hypoglycemia. It can be intentional either by the child or the caretaker where they're giving more insulin just to curb the hyperglycemias, or accidental infusion not calculating the carbohydrate appropriately. And again, the psychosocial stress for maintaining the blood glucose values can cause more problems to the child. And of course, the weight gain, because you know there is insulin pump, you know there is insulin which is given to the body continuously, there can be a tendency of the child eating more and causing weight gain. And of course, the cost, yes, we do have studies which was done in UK, England and other places where we have NHS which is covering the insulin pump cost. But whereas in India, we are struggling even to get a CGMS on a child, forget the insulin pumps. So cost effective has to be dealt with, like Dr. Anushree said, we have to approach the government at least to get a CGMS first and then the pumps. So what is the take home message at the end is, yes, insulin pump can be started at any age group. There is no criteria for starting an insulin pump, but remember there are certain complexity when we are using an insulin pump. It requires a lot of training, lot of understanding of the device. Of course, the lifestyle and the comfortable. The child has to carry the pump throughout. It's like it's his or her companion throughout his life. So he has to carry the insulin pump with him. Technical issues, as I mentioned, it can be a lot of problems causing risk factors for diabetic ketoacidosis, hypoglycemias, and other risk factors. And at the end, it is the cost, which is a big issue, at least in the Indian. I finished much before the time.
So I'll call both the people on stage. I'll give you my viewpoints. So I think both are very excellent presentations. I'm Dr. Mithun Bhartia. I'm an endocrinologist at Guwahati. A few things which I would agree with both of you. I think before insulin pump is ideal for all type 1 patients. It's the best thing that everybody could have. And if you have automated insulin pump, that's much, much better. Realistically, what we can do in our daily practice, make sure no type 1 diabetic patient is on any regimen other than basal bolus. That is something which is in our hands. That is something which we should do. Premix insulin should never be prescribed for anybody with type 1 diabetic. As you mentioned before, carb counting, I think we should get the patient's pump ready. This is what I do. First of all, every person who prescribes insulin pump should wear an insulin pump. As a doctor, till we cannot feel what it feels like sleeping on one side when there is a thing on one side or नींद नहीं आती, फिर नहाना कैसे है, ये कैसे है, till we do not answer kinking क्या होता है, my suggestion or when I train my people is that I make sure each doctor wears with saline water ताकि आपको वो feel भी आए कि कुछ जा रहा है body में. So you can understand what does it feel like to be an insulin pump. And when I feel my patients are ready, I first make them wear it with saline water and ask them to play with the settings. See if they can, if they cannot, and I ask them to do carb counting and then play with the settings. In that way, you have screened your entire population whether they can do carb counting or not, because what we don't want is a regressive step. You put somebody on pump and then you're taking him off for it. The better thing is to screen everybody and decide whether the person can go on an insulin pump or not. And if he can, he's passed the carb counting, he's felt it, he's ready, school जाएगा तो कोई पूछेगा क्या करने का क्या नहीं करना है. So I let them go to school with it as well, with saline water, so that they can understand the ecosystem. And once they are ready with it, I get them to meet the people who are already on insulin pumps, so that they are motivated enough, their problems is discussed, so that the chances of failure are low. Cost is a problem. Cost effectiveness study, I was in UK, you're right, because the government is paying for everything. The amount of risk of hypoglycemia admissions or DK admissions, उनके लिए pump दे दो ज़्यादा सस्ता पड़ता है. हमारे यहाँ नहीं होता है ऐसा, people self pay. So cost effectiveness study will be very difficult to do in India. But as a overall, there are a lot of places where people may be able to fund. You can start a GoFund scheme for the child. And so some support may come from that perspective. But yeah, in an ideal scenario, I think we were trying to get a insulin pump made in India. That's under progress. Hopefully, if it sees the sunlight, then the cost will come crashing down. The cost comes crashing down, then even the MNCs, Emetronics and everything will bring the cost down, and it would be a reality for every type 1 to have a patient. Type 2, I don't think there is much there for an insulin pump. Fashion statement is a different matter, but there's not much of indication. With that, if anybody has any questions for our
So thank you for making the point that pre-mixed insulin is not recommended, because I do see many prescriptions even today when they come to me with pre-mixed insulins, and the patients are very happy to take it because it's only twice a day when compared to the basal bolus, which is 4 times a day.
So I think if you're doing premix insulin, you should not practice diabetes for type 1. You should not see the patient. I am very,
Thank
there
you
is
for
no black and
putting
white in
that,
that. It's
yes.
very crystal clear.
Both the speakers have done the justification for the topic, but being both the pediatricians, they have discussed about this pediatric aspect only. I'm being a physician. In the last slide, you mentioned that that can be used for all ages. At the same time, you said for the type 2 adults like this, there is no advantage. Really, I want to know whether the type 2 diabetic patient who is doing practically well, but the TIR, time and variability, is not very good. In that situation, whether the insulin pump should be a good choice or not.
I think let's break down when you say type 2 patient, what do you mean by type 2 patient here? Okay. In a type 2 patient, there is insulin resistance. In type 1, it's a purest form of diabetes. You know the person needs insulin, you are giving insulin, crystal clear. In type 2, there is insulin resistance. And so it's very difficult that they need insulin is the answer is not the question. They may need insulin sensitizers, they may need to lose weight. And so nowadays there are modern therapies that are available which works in type 2 rather than going down the pump era. You can use a lot of CGMs and find a predictability with these medications. I'm not saying you cannot use, but the indications are very low. Yet there might be some patients who are very insulin sensitive in type 2 patients, because nowadays it's not purely type 1 and type 2. There's a lot of intermingling in between them, between the two shades that are there. It's a lot of gray in between the black and white. But TIR, see, you have to understand what TIR is. My view of TIR is refurbished wine, old wine in a new bottle. Okay. What we are trying about TIR is that the person's diabetes should be under control. He should not get hypoglycemia. He should not get hyperglycemia. That is the meaning of TIR. Whether now we put a term across it is different. That's a different matter. So I think the fight should be to bring them in a narrower glycemic variability. That is what you're trying to do. And that can be achieved if you can reduce the glycemic if you can reduce the glycemic variability with a lot of newer agents that are there. Some patients will require insulin. A lot of type 2 patients over the periods of time start behaving like type 1. Please don't give sulfonylureas to these patients. If it's type 2 patients had been on there for like 15-20 years of type 2 and you are giving insulin plus sulfonylurea is like, what are you doing? Somebody who's not, because what sulfonylurea does is goes and kicks the pancreas to secrete more insulin. The pancreas is a tired donkey, then what are you going to kick him to get more out of it? So combination of sulfonylurea with insulin in abroad is not given. So I think that effect, but there cannot be a single rule. It's just as a general thing I'm saying.
So that means just to improve further better control, the insulin pump cannot be a good choice into the adult. That means.
So I think there is nothing called in medical all and none. Okay, there cannot be, it can never be used. It can be used, but if I have a choice and I have to fund one type 1 or type 2, definitely I'm not going to go funding down a type 2. Now, patients are self-paid. If they want to put one, you can't do anything about it. Medtronic would be very happy, the doctor would be happy, everybody would be happy. That's a different matter.
That means only the Medtronics will be benefited, not the patient. Thank you very much.
Thank you.